Welcome, everybody. Here we are at the University of Colorado Denver College of Liberal Arts and Sciences. Our series this summer is Conversations about COVID. Um, Here we are, and where are we going? My name is Marjorie Levine Clark, and I'm a professor of history and the Associate Dean for Diversity Outreach and Initiatives in the college. And like last summer, I'm moderating this series. And we had this series last summer. I'm sure some of you are aware, COVID-19, Colorado and beyond. And I think we really didn't know what we were in for at that point. The pandemic has affected our lives across multiple realms, really all realms, our physical and mental health, our relationships, our politics, our economic lives, the ways we communicate, and the ways we just generally interact with the world around us. The 4 sessions of this interdisciplinary series this month will help us understand where we are now and where we are going as we continue to negotiate the stages of this pandemic. The lectures will be recorded and they'll be made available on the CLAS YouTube channel after they're presented, and I think we're going to put the link for that in the chat. For Zoom etiquette, please keep yourself on mute for the lecture, and please use the chat feature to ask questions. If we're small enough, we can perhaps unmute for questions, but if not, we'll use the chat and I'll try to get to as many questions as possible after the lecture. I want to thank our outstanding faculty who volunteered their time for this series. I also want to thank Tracy Combe, our CLAS Marketing and Communications Director, Tim Stalker, our CLAS Webmaster, and Kristen Salisbury, the Program Manager for CLAS Continuing and Professional Education, for their help on the technical side of putting this series together. Our lecturer today is Dr. Jonathan Samet, who's Dean of the Colorado School of Public Health on the Anschutz Medical Campus. He received his medical degree from the University of Rochester School of Medicine and Dentistry and a Master of Science degree in epidemiology from the Harvard School of Public Health. Dr. Samet is a pulmonary physician and epidemiologist. His research has focused on the environment and the lung, including air pollution, tobacco, and radon. And he's leading the COVID-19 modeling group and has recently published on tobacco and the risks of COVID-19, as well as what we know about the airborne transmission of COVID-19. He's chairing a committee on respiratory protection for the public and workers without respiratory protection programs at their workplaces for the National Academies of Sciences, Engineering, and Medicine. And this committee grew out of concerns with respiratory protection due to COVID-19 and also the increase in wildfires. His lecture today is titled The COVID-19 Pandemic in 2021, Lessons Learned and Challenges Ahead. Welcome, Dr. Samet.
Great, thanks, Marjorie. It's nice to be back, and let me pull up slides, which I've learned how to do, and get started. And give us a moment. I hope we should be. Oops, sorry. Let's see. I see the problem. All right, and we should be ready to go. Okay, so what I'm going to do is provide a general background. Think back to a year ago when I gave a talk in this series, and then talk about where we are now and end up with a little bit of speculation about the future. And it looks like we're a pretty small crowd, and if as I go through things, somebody has something they want to bring to my attention or amplify on, maybe put it in the chat, and perhaps then Marjorie, you could flag me down. So some basics, some reminders, and this is sort of from last year's talk, but coronaviruses. So the structure, what is important? They're called coronaviruses because they have spikes. And there's supposed to be a semblance here to the spikes on a crown. And of course, we've learned a lot about the spike protein because it's the target for our vaccines. So it's the piece of the virus that binds onto receptors on the cell's surface. It's the way that the virus gets into a cell and does its job, which is to reproduce itself. So the virus is, in this case, it's an RNA virus. Its purpose, so to speak, is to replicate. It's the SARS-CoV-2, which causes COVID-19, is not the only coronavirus that is known to cause human disease. So there are four that cause the common cold. There's SARS, some of us remember well from 2003. There's the virus that causes MERS, or Middle Eastern Respiratory Syndrome. And now, of course, we have SARS-CoV-2 and the disease COVID-19. So these viruses are fascinating. There are many of them. They live in nature, they mutate, and they jump. They've jumped from animal to man. And of course, now there's a lot of speculation, discussion about the origins of SARS-CoV-2. Was this from bats, and where? Is there a possibility of a jump from a laboratory? And I'm sure you all know that. So takeaway, RNA virus, spike protein is really important. And just a few true basics of epidemiology. Disease that is outside what we expect in place and time, person, is an epidemic. The disease that hangs around and is always with us is endemic. And of course, with the SARS-CoV-2, there's been a lot of discussion about it becoming endemic, living in us, reemerging, constantly mutating, and might be with us, who knows, possibly forever. We'll find out. Pandemic, it's a global epidemic. And certainly we are right in the midst of one of those. Now, I'm also going to talk about epidemic curves. That is the rise and the fall of the infection. We had a nice opportunity early on to observe the epidemic curve for SARS-CoV-2 and COVID-19 on the among the passengers on the Diamond Princess cruise ship, of course, which ended up docked off Japan, and the people on board becoming ill and eventually evacuated. But if we look at the epidemic curve, the orange is the passengers in close contact with the index case, the rise and the fall, of course, and then the spread to others. And you can see, for example, the secondary epidemic curve in blue in the passengers. So by the time people were off the ship, about 20% had become infected. Usually we wouldn't have the opportunity to observe this because people are not captured in a boat, and we can observe the whole course of the infection. So we talked a lot early on about bending the curve. And at the start of the pandemic, many modeling groups, including ours, made projections like this: a spectacular rise in number of cases. And what we wanted to do was to avoid that and, quote, bend the curve, bring this down by using the protective measures that everyone knows now. So the epidemic curve is a critical feature. You've also heard about the R naught, the R sub zero, the basic reproductive number. So this is the number at the start of the epidemic when everybody, 100%, are susceptible. And it depends on how much people contact others, the probability of infection when a contact occurs, and how long people are infected, common sense. Now, one problem with that variance is that they're more transmissible. So this P goes up, probability of infection when a contact occurs. So we think at the start of this SARS-CoV-2, maybe the R naught was around 3 to 5. And, again, we've estimated it, many people have estimated, but numbers are sort of in that range. And that becomes important in part because it relates to herd immunity, another concept you've heard a lot. What we want to do with an epidemic, of course, is to end it. And the way to do that is to have measures in place that lead to extinguishing the epidemic. That is, one person who's infected infects less on average than one person, and the epidemic curve goes down, the epidemic dies out. So herd immunity, we want to achieve, we want to have the percent immune sufficient to keep now what I'm calling the effective reproductive number below 1. That's the reproductive number, the number of new cases caused per infected person as the epidemic proceeds. And there's a very simple formula to calculate it at its most simplistic formulation. So just 1 minus 1 over R naught. So if R naught is 3, then we're aiming for about 70% of people to be immune to have herd immunity. Okay, and here's the world's only, I think, herd immunity cartoon. So the mathematics, the way epidemics work is in some ways simple. If we start with 100% susceptible, people become infected, the number susceptible drops, and as time goes on, hopefully people recover and are immune. Now, of course, with SARS-CoV-2 and COVID-19, some people who are infected become sick, need to go into the hospital, and some of those people don't make it, they die. And so the real world is more complicated, but what we do in our models is we start with this basic idea of susceptible to infected to recovered, and we create mathematical models, here's our team, that describe these transitions. We strip nature down to its barest elements, like Picasso does here for this bull. And you can see that all the basic elements are maintained. So we model how nature works, and we do that for the purposes of understanding where we are, and also for projecting where we might go. Now, some people are skeptical of models. We've certainly encountered plenty of skeptics as we have done our work for the state of Colorado. But as a reminder, this quote from a statistician, all models are wrong. True, we can't really capture all of nature, but some are useful. Also true, and we've spent probably a year and a half now meeting more or less weekly with the Colorado Department of Public Health and Environment and the governor's office to talk about what the models are showing. So as I said, we use the models to look backwards and say what happened, and then say what will happen or what could happen under different scenarios. A lot of our work was intended to help avoid catastrophe, the catastrophe of exceeding our hospital capacity. So as we looked at the tools available, distancing, protecting vulnerable people, older people, case identification, isolation, contact tracing, and masks, we said, what tools do we need? And what is going to happen when we use these tools, when we up contact tracing? So we all have learned social distancing. Hopefully everybody knows the cover of Abbey Road and the distance between the Beatles at that moment who were about to break up. We know that some people are far more vulnerable to severe illness than others. We know the importance of case identification and isolation. This is an outbreak on a bus in China. We certainly know about contact tracing. We have now apps to do that, new techniques. And of course, masks. And this is a favorite picture from last year with our governor meeting Vice President Pence, mask and no mask. And I think everybody knows that masks have become, even though a valuable public health tool, highly politicized. So in the end, our model looks something like this. It's actually more complicated now because we've added in vaccination. But we go on this side to people who are susceptible, and on the other side to those who have been infected, maybe with hospital or without, and some have died. And we use the models to project this, and important tools for being able to make plans. So I want to go back to last year when I spoke, and here is Colorado's epidemic curve as captured in the number of people on a daily basis in hospital for COVID-19. And the blue is the confirmed COVID-19, and the addition in the brown is those who are suspected to have it. So here's where we started. Just to give you reference, we wanted to avoid breaching our ICU capacity and our hospital capacity. We had about 3,000 beds available statewide for intensive care if needed. And we were trying to avoid reaching that number. I'm sorry, we had about 3,000 beds available for hospitalization for COVID-19.
What? Sorry, he's not getting enough sun.
It had been open.
Okay, so
Got you hot.
oops. I think somebody needs to mute, maybe. Anyway, so you can see where the curve was then and where we are now. And remember, we started vaccinating back here. We had this horrendous peak. And now we are coming down and coming down, although we've been plateauing. And each time we did not come down nearly so steeply as last year with January. And here we are resuming life, getting vaccinated, and we still have about 280 people in the hospital. Back in here, our low was about 126, 130. So the pandemic has had its ups and downs, certainly in the state. So last year we were emerging from lockdown. There was lots of controversy about small droplets, airborne transmission, surfaces, masks, how did we get to herd immunity? And of course, vaccines. The phase 1 and 2 trials were coming to a close. That is the ones that sort of prove that a vaccine can cause antibodies and the risks are going to be acceptable from initial indications. And then the phase 3 trials are the ones that go out into the community and actually see if the vaccines work. So those were getting underway. So this is a year ago. And of course, we weren't really sure where things were going to go. So what have we learned? Well, we certainly learned that all these so-called non-pharmaceutical interventions, distancing and so on, work. Took rather long for the scientific community to agree that these small particles, aerosols, are critical, and lots of implications for that. It means that, yep, the 6 feet distancing protects you against someone spraying larger droplets onto you when they cough or sneeze, but it doesn't protect as much or as well against these smaller particles which can travel around rooms and stay suspended. We certainly have effective vaccines, and I'll go into that a little bit. Vaccine hesitancy, which I think you'll hear about from Jennifer Reich later on, is a big problem. Colorado reached 70% with at least 1 dose of eligible adults this week. Nationally, we're at 67%. And it seems like there's a minority determined not to be vaccinated. We now understand that these mutations of the virus, alpha, beta, delta, so on, produce variants that are a problem. And right now, most of the isolates in Colorado are the so-called Delta variant. We know that age, obesity, diabetes, heart disease, and so on affect clinical outcome. We're learning about long COVID, which seems to affect a substantial minority of those with more severe disease. And certainly we've learned how COVID thrives on inequities. And certain populations, notably Hispanic, African American, American Indian, Alaska Natives, have been hammered by the pandemic. On the transmission side, with really important implications for control, at the start, we knew of different ways that this infection might be transmitted. Contact, touching surfaces, so-called fomite transmission, large droplets, spray, I think you know what that means, and smaller particles, aerosols, traveling. And where have we gotten to? Well, we've learned that this source control is important, that with masks, we can avoid spraying large numbers of particles. So masks are about protecting ourselves, and they're also about protecting others. I think a point that too often gets lost. Of course, social distancing helps. Dealing with our buildings, making sure that there's a flow of fresh air. Cleaning has also been cited, and there are strong advocates scientifically for that at Boulder, Jose Jimenez and Shelley Miller. So people looking at ventilation systems. This is an area that long needed attention, but had not had much. So of course, distancing and using personal protective equipment. And as was mentioned, I'm chairing this committee now looking at how do we do this for the nation when needed. So protecting ourselves from spraying onto others and protecting ourselves from inhaling particles using various forms of personal protection. And then, of course, we've heard a lot about hygiene. So what we've really learned is now that we want to use all of these together in a strategy for preventing infection. So here we are with that. The vaccine story is remarkable. I think when the pandemic began, I'm sure somebody asked me, last year when I spoke, when are we going to have vaccines? I didn't say I would be vaccinated next year. I probably said, boy, we want vaccines, but it's probably going to take a couple of years to get there. So here we are. We have multiple vaccines available worldwide, 3 approved for use in the United States, of course, the 3 at the bottom here, and others approved by WHO and other national authorities for use. And these vaccines are good. These 90+% efficacy rates from the phase 3 trials are remarkable and certainly better than we often achieve with seasonal flu. Not 100%, and they also mitigate against more severe disease. So we have vaccines, we have technologies that will allow us to change them quickly for variants. We have a lot to learn about how long immunity will last from vaccines or from natural infection, but the work is in progress to track and help us. The variant story, I think, was to be expected. This is sort of the path of mutations across the strains as they have mutated. So these RNA viruses mutate more than DNA viruses. And the way this works is a little bit Darwinian. The most transmissible or the more transmissible strains win the race to dominate. So you'll remember we had the alpha strain, the B117, the strain that originated in the UK. Now we have the delta strain, which originated in India. The alpha about 50% more transmissible than the strains that were circulating, and now the delta 50% more transmissible than the earlier one, the alpha. So the more transmissible strain keeps winning out. They make their way around the globe, as you can see in this picture. It's just, of course, unless you're perhaps New Zealand or Tasmania or Australia, countries have not been able to isolate themselves from the spread of these variants. So if we look, just going to run through a series. This is the alpha, the B117, and you can see where it is and verified and unverified. Here's the beta version. They're making their way pretty much around the world. Here's the Delta version. You can see, for example, much of sub-Saharan Africa, I think we just lack information. Been working in this part of the world right now, and it's very challenging to know what is going on. And then there's the gamma. So we have multiple variants, and there are certainly going to be more, and we need global surveillance to keep track of these. Here's Colorado, and again, you can see the dominance. We estimated that it's probably 90+% of the isolates now are the Delta variant in the state. So we'll close by taking you on a quick tour of where we are now, globally and in Colorado. So globally, this figure of 4 million deaths has to be a gross undercount, perhaps twofold at least, and perhaps more. The United States has led in the number of deaths. And of course, here is Brazil and India with their very high totals. The pandemic is in reality a series of epidemics. Whether we look globally, as shown here with different epidemic curves, or as you'll see in Colorado, where right now the epidemic's course very much follows with the rate of vaccination. These are the hotspots, which are continually shifting as curves rise, measures are implemented, and now, of course, the hotspots are going to be very much more congruent with vaccination rates. But this map has changed over time. So here we are in Colorado. I showed you these waves, cases, deaths, which fortunately seem to be following. Colorado in total is about 6,600 deaths. Then I showed you this curve already, the admissions, and right now we're on this seeming plateau. I'm hoping that vaccination will rise and bring this down. I'm going to show you some vaccination data. So here's the U.S. proportion receiving at least, share the population receiving at least one dose. We're sort of in the middle of the pack as a state. I was just in Rhode Island visiting a grandson, and they're heading for 70% plus fully vaccinated. So ahead of Colorado, for example. Disturbing, of course, is this fall decline of vaccination in the state. While we still have many to vaccinate, we're doing quite well in the 65 plus, heading for 80% vaccinated, but in the other age ranges, we have a lot of work to do. We're not reaching all groups equally. This shows the percent vaccinated versus the percentage of the age group in the population, not doing as well with younger people, the Hispanic population, again, where we are lagging, and in males. And I'm going to show you the geographic distribution now. So if we look by county in the state, we see a huge range across the county. And I'm going to show you some additional, across the counties, I'm going to show you some additional data. You can see some areas like these central mountain communities where we're doing quite well, the Denver metro area, but in some of these outlying counties, particularly more rural areas, rates are much lower. This is really important data. So what I'm showing you is the rate of vaccination over time in different age groups, 12 to 19, 20 to 39, 40 to 64, 65 plus, for 11 different public health regions in the state. So for example, here's the metro in blue, and down here is this East Central region, down South and Central, I'm sorry, East and Central, and you can see the vaccination rates are low. So notice a couple of things. It's incredible spread, even amongst those who are older, with rates of vaccination ranging from 80% plus to about 50%. Or in the 20 to 39, we're going from just over 60% down to about 20%. There's a huge range, and it's consistent across these age ranges. So this is where we have, as you know, a variety of incentives and initiatives to encourage vaccination. We know that vaccination works, and this is nice data from the state. This is cases, hospitalizations, 15 largest counties. I'm just plotting the rate against the percent of the population fully immunized. And you can see, big surprise, the greater the percent of the population immune, the lower the rate of hospitalization and cases. Here's Mesa County, an outlier, maybe because it was where we first saw the Delta variant hit hard. So very frustrating from the public health point of view, and lots of work in place to do that. So just to go globally for a moment, we face an enormous burden. I bring this to your attention because the pandemic's not going to be over until the world is vaccinated, or much of the world is vaccinated enough. We have an incredibly long way to go. I think you saw that earlier on. You may have noticed that 3 billion doses have been administered globally. But if you look at sub-Saharan Africa, parts of Asia, parts of Latin America, barely anyone has been vaccinated. So a tremendously long way to go. And I think it's well recognized the need to vaccinate. The higher income countries are stepping up through a variety of ways, but there's much to do, and it's going to take a long time. So we saw a little bit before about who has been hit the hardest, and we just again reiterate the point: have to work to reduce this incredible global burden of disease. So, turning to what might happen next, a lot of things are going to happen. Summer is coming to a close, and we may have had a benefit of the warm weather. We thought that might have happened last summer. It's certainly less apparent this summer. Schools will reopen. We're going back to our workplaces, and we know that there's more mobility and more contacts among people. If you think back, those who were infected early on are now a year and a half out from their infection. It could be that natural immunity is beginning to wane. Variants are going to continue to come. So we're not done. This July 4th was not Independence Day from COVID-19. So what's the end game here? It's vaccination. And we really want to avoid all the measures that were needed, the non-pharmaceutical interventions, the distancing, the masks. We're very reluctant to continue to follow those measures. Fortunately, right now, they're not needed to avoid a healthcare delivery catastrophe. But that said, we still have many people infected and many people dying, whether it's Colorado, the United States, or globally. So vaccination is just critical. Just in closing, draw your attention to some resources that may be useful. I'm writing a weekly commentary, which often points to key resources or events. We have created a website with a great deal of Colorado data. The reports from our modeling team are posted. We did a series collaboratively with the Denver Museum of Nature and Science, 30 presentations, and these are now all archived and summaries, written summaries are available. There's actually a several hundred-page compendium of all the summaries that's available, and you can download it. So let me stop here, and looking forward to speaking with you.
Great. Well, since we're all on one screen, maybe if people want to raise hands, or you can ask your own questions, or put
Yeah,
a
just
question
chime
the
in.
chat.
That's just fine.
Huh?
Yeah, just talk away.
Yeah. Questions, comments? Yeah.
Can I ask something real quick?
Oh,
Yeah, Yoshi.
Okay, so thank you for the presentation. So real quick, I have a lot of friends who aren't willing to get vaccinated, and they keep bringing up the point of like, well, more people have died from the flu than COVID. So they just see vaccination as like, I don't know, they're very against it. They believe in a lot of the vaccine injuries. And so it's been pretty frustrating just talking to them. I went and got vaccinated because I work in the hospitality industry, so I'm around people all day long. It has not stopped for me since the start of this at all. I've seen so many people and just being a server, and so I went to go get vaccinated because I was just like my exposure is so high, and so I'm still continuing to wear the masks even when I'm working. And so it's like offending my friends that I'm even wearing my mask. They're like, you've already gotten COVID. You have the vaccine now. Like, why are you still wearing the masks? And it's like, I'm wearing it because you won't get vaccinated, but it's like, at that point, like, how do you convince people like this to like, go get vaccinated?
Sure. So, yeah, I mean, you put your finger on a really important challenge for all of us. So one is your friends have the facts wrong. 600,000 or 660,000 people don't die of flu every year. Even in a bad year, 60, 70,000 would be a very bad year. So this is much more lethal than flu. And, and globally, the toll is incredible. The discussions about mask safety, and I think I've heard probably all the arguments. Some are frustrating. There's this sort of, gee, I just don't believe in these vaccines, or we don't really know enough about them, or they're not approved by FDA yet. We are using them under emergency use authorization. I think you're young, but young people are dying of COVID-19. So anyone who thinks, hey, I don't know, make up an age, 30, and I'm not going to get sick, they're wrong. We've had people in the intensive care unit in their 20s, and some of them don't make it. So, there's a lot of misinformation. One example that I've heard that is not true, but I can understand its origins. Well, these vaccines affect fertility. I don't think they do, because I can't think of a way that they could affect fertility. So, again, I think if a woman were pregnant, she said, they haven't been studied in pregnant women, which is true. I'm going to wait. That makes sense. I'm continuing to wear masks. The vaccines aren't 100% a surety, so there are some breakthrough cases. They're not generally very severe, but if you're, working in the hospitality industry, interacting with hundreds of people daily, and you wear a mask because somebody may sneeze on you with those spray droplets, you're going to be protected. So, your friends aren't armed with the facts. And of course, there's so much misinformation circulating, which is yet another challenge. And I suspect we'll come to that later in the series. And everyone in public health right now is working, very hard to try and keep pushing to get that percentage up. And it's just getting harder and harder to do, unfortunately. I see Jennifer's on. She may want to comment here.
Maybe she's away from her screen.
Yeah, yeah.
Other comments or questions?
I have a question. So I've heard, and I haven't been following what studies are being done, but I have heard people talk about combining multiple versions of the vaccine for increased immunity because they target a little differently. So I'm curious what your thoughts are on that. And somewhat related, so sorry, I'm going to sneak in a second question. What are your thoughts on the necessity of a booster?
Yeah. So, let me deal with the booster question first. I'm sure we'll get the boosters. And we'll get the boosters probably for two reasons. One is we're going to learn eventually that immunity wanes following vaccination or following infection. And second, it could be, though it hasn't happened yet, that we will need vaccines that deal with variation among strains. I mean, so far, the vaccines are all directed at the spike protein, and they seem to work. I mean, they're all dealing with the spike protein through one mechanism or another. So I can see that there could be multiple reasons to think about boosters. To me, the time of when is not so clear. The other point I'll make with these mRNA vaccines, part of the one feature of the technology is it's relatively easy for the strains that the vaccine will target to be changed. So it's really not a big challenge to do that. The question about mixing vaccines, and I think this has come up most often for the relatively small proportion of the population that have had the J&J vaccine, which is less efficacious. And then this question of, gee, why don't I go get a shot of Moderna or Pfizer or whatever, get vaccinated? It makes sense, but it's not been studied. And, I think, listen to the experts. If you listen to Tony Fauci, he's not supporting that strategy, right now. I think the good news is that the J&J vaccine seems to provide protection against serious infection with the Delta strain. So that helps. So, we'll probably get some studies. I don't think we're going to do these phase 3 trials of vaccines, but I suspect somebody is looking at the immune response and how it may be augmented, probably particularly if you got J&J and then had the addition of the Pfizer or the Moderna.
Great, thanks.
So we have a question in the chat. How well do you think the vaccines prevent infection and asymptomatic transmission of vaccinated people? In other words, to what extent are they inducing sterilizing immunity?
Yeah. So it's an interesting question. This question of for those who have been vaccinated, how frequently do they carry virus and could potentially infect others? The data are really limited. And the data we have looked at came from, either Pfizer or Moderna, where they cultured people, swabbed them at their last visit. And in some percentage, it's not large, viral RNA was recovered. Now, the challenge here is that's quite different from could these people transmit infection? So the question of viral carriage versus transmissibility of infection is a complicated is a complicated one. So I think the answer is probably not in. I mean, I think one thing that is clear, it's clear in Colorado and elsewhere, that we do get breakthrough infections in people who've been vaccinated. But 90% efficacy is really good. It's just not 100%. And so, the good news is may not be 100%, but there's protection against more severe disease.
And another question in the chat. Once we have COVID antibodies, does this mean we are immune from COVID for life? Another case in argument from my friend who won't get vaccinated since she already had COVID.
Yeah, so we're probably not immune for life. How do we know that? Well, with SARS,
Right.
people who were infected in 2003, the immunity waned. And there have been studies with the other, remember I said there are 4 coronaviruses that are commonly circulating and causing the common cold. And immunity to those we know is not lasting either. And there's not good cross immunity, and you can get reinfected with the same strain. So, we're not going to get lifetime immunity. We don't think it could be. It seems that cellular immunity, seems to last surprisingly long, but, we're a year and a half into this. We've got a lot to learn.
What strategies are being used to improve vaccination rates in the areas of lowest vaccination in Colorado?
Boy, I would say everything. It's really a challenge and a frustration. The Mesa County, which has such low vaccination rates, had Country Jam 2 weeks ago, I think. And maybe 20, 30,000 different people go there. They had their vaccination ban there. And my understanding is a handful of people were vaccinated in what may be a relatively low vaccination rate area. We have funds from CDC at the school and are working in a number of areas, the San Luis Valley and some of the counties going north from there. We're trying things with sort of peer group leaders, social networks, the kinds of things you would think about doing. So that kind of work going on. Of course, we've had lotteries, we have cash incentives, and I think the other is mandatory vaccination policies. And of course, the CU system has said people will be vaccinated, and there are going to be penalties for not. So I think as we go back to workplaces and schools, hopefully we will see the vaccination rates rise. But I think we're doing an awful lot. When smallpox hit New York in, I think it's the early 40s, they rapidly vaccinated the whole city. There are these pictures of lines of people lined up to get vaccinated against smallpox. I never heard of vaccine resistance, hesitancy for smallpox. This disease is pretty lethal. And, for those who think they're not susceptible or vulnerable, the real answer is everyone is. And, this issue of getting vaccinated, not only for yourself, but altruistically for everybody, it's really important that we do so. And it's part of getting back to the life, leading the lives we want to live.
Now, we have another question. Another several. It almost seems inevitable that with the spread of COVID and the opportunities for variants, that we'll someday have a variant that defeats the vaccines. Predictions about the future are perilous, but do you have thoughts on that?
Well, I agree that predictions about the future are perilous. I'm not the right person to say, could a vaccine immune variant come along? Because, it's this question of the virus needs the spike protein to bind. It binds to those ACE2 receptors that we've heard about. It's a particular configuration, it's a particular thing. It's something to which we can generate immunity. So I'm not sure it would be a SARS-CoV-2 that comes along that is not going to be blocked protection provided by the current vaccines. I mean, I think the concern, of course, is that there could be spillover of yet another coronavirus, and then we would be potentially back. I mean, certainly, regardless of whether this, the spillover was from, bat to man or bat to mammal to man, or from a lab, we learned it could spread awfully quickly, this virus. And this virus has a number of characteristics that make it really challenging. It has an asymptomatic period during which people can spread it. SARS made people acutely ill very quickly, and they sought medical care. And there were 8,000 cases, so we were lucky. So to me, the worry might be, what is the next coronavirus that's going to spill over of the thousands that are out there?
So we have two related questions. So I'll give them to you together. What are your thoughts about young children and the more contagious variants? And then, is September, October a good estimate for when school-age children under 12 will be able to be vaccinated? Many districts in Colorado start school in early to mid-August. Do you think delaying school to after Labor Day would be a good strategy to prevent outbreaks?
Yeah, my sense, and we've asked. I mean, the probably the under 12 vaccines are going to be at year's end, perhaps, to get there. So that doesn't coincide with school. I think things that probably the politicians or the decision makers won't do, and that parents in general might not tolerate, is delaying school opening. And because of its incredible consequences for everybody. So that, I think, is not going to happen. I think the children, of course, are largely asymptomatic, except for the unfortunate minority who get this multi-system inflammatory syndrome that can make them quite ill. So I think we may be back to business as usual around schools. I think the question of how we're going to, manage, assuming that teachers are going to need to be hopefully vaccinated, that there again is another issue to protect themselves. But I think schools will be open. I think people are concerned that there could be a fall surge, and that probably be driven more by going back more indoors, closing our buildings up, schools reopening, and back to workplaces. Our universities opening again, which we certainly will be doing.
Right. Are there any new vaccines being made? And do you think that if there was a vaccine other than J&J that was one dose, that more people would be willing to get it?
Yeah, I haven't, at the start of this, there were 100+ vaccines under development. I know that some have failed completely. I don't know what's in the pipeline around sort of moving on to phase 3 trials. I mean, in a way, we have remarkably effective vaccines. I think the question of single dose, if you want to get the world vaccinated, what could be better than a single dose vaccine? So I think if we had someone, and the J&J has many desirable characteristics in that regard, including not needing this, cold chain that the others do. And if I mean, its efficacy seems to be lower for some strains, but if it did have 70% efficacy, that's pretty good. one model you might look at is smallpox, which of course we were able to eradicate because you were only inoculated once, acquired lifetime immunity, and of course man was the host. There was not any other species out there that carried smallpox. So I think if we had a great single dose vaccine that we could deliver, maybe better than J&J, I think it would make a huge difference.
So we have a final question. Do you think vaccination exemptions for things other than medical or allergy will be overused or impact vaccination rates or mandatory vaccination policies?
So I think the answer is, if we're not careful, it could. And the policy, certainly on our campus, and presumably yours, is that medical exemptions are allowed. Now, I think there are relatively few medical exemptions. I mean, I think somebody who's truly had a reaction, say, to a first dose, and I understand that such as happens, should not get a second dose. People who are immunocompromised in one way or another should be vaccinated. I know our attorneys and attorneys on your campus are looking closely at what constitutes religious exemptions. And certainly the idea of personal belief exemptions is not one that is, I think, easily supportable. I mean, and certainly, for example, the experience in California with parents seeking exemptions from some physicians, providers who are notorious for providing exemptions, it's not what we should be doing. So I think we need good protocols for deciding when there are exemptions. Although, and I'll just speak to our campus and what we intend to do. We will allow, those exemptions that are certified. It becomes a major challenge then about how to integrate those who are not vaccinated into the activities of the vast majority who will be, because they will need to be distanced, they will need to wear masks, and likely they'll need to be tested. So we're hoping that we can return to classrooms sort of at full occupancy, but somehow we'll need to accommodate however many end up with exemptions. So it's certainly going to complicate how we return to sort of life.
Yeah. And we'll have more on vaccines and vaccinations in 2 weeks, right, with Professor Jennifer Reich. So I want to say thank you so much, Dr. Samet. This has been a great conversation and great presentation. And I think the emphasis on that we're not done, we have ways to go, and that we all need to protect ourselves and protect others, right, is really a big takeaway from all of this. So thank you very much.
Yeah,